so we'll talk a little bit about pediatric GI disorders. First, starting with acute infectious problems, diarrhea. Acute infectious GI can be caused by E. coli, C. diff, rotavirus, salmonella, and dehydration for kiddos can lead, diarrhea can lead to dehydration very fast in your kiddos. Acute cases are usually secondary to infection, such as a virus. Chronic diarrhea defined as more than 14 days. Possible causes could be food allergies or inflammatory bowel disease. Children at increased risk if they have poor hygiene, dirty water, crowded living conditions, and poor nutrition. Your ATI book has a good little chart with descriptions of different infectious diseases. Diagnosing these infections are done by stool sample or cultures, a CBC, H&H, and a UA, and this can help determine dehydration. Nursing care, medications that can be given, Flagyl if it's C. diff. You want to avoid anti-motility agents if the child has E. coli or salmonella poisoning because you want that body to get rid of that infection. Education, you want to tell the client to avoid juice, soda because of the high carb content, caffeine because it's a diuretic, it's going to dehydrate them more. Take preventative measures, check skin assessment for breakdown. Children dehydrate much more quickly than adults, and that's why you will see kiddos hospitalized for vomiting or diarrhea so they can get IV fluids, where adults most likely are not going to be hospitalized for that. Oral rehydration therapy is preferred if the child can keep it down. If not, then they may resort to IV fluids. Fluid, electrolyte, and acid base. Dehydration occurs when there is excessive loss of body water. So we're going to differentiate isotonic, hypertonic, and hypotonic dehydration. In isotonic dehydration, water and sodium are lost in equal amounts. This puts the patient at increased risk for hypovolemic shock. So you would give an isotonic fluid such as normal saline for this. Hypertonic dehydration, water loss is greater than sodium, causing a shift from intracellular to extracellular, so the water moves out of the cells and shrinks. This is seen in DKA. So with this, you would give a hypotonic fluid, such as half normal saline, to shift the water back into the cell. So to help you visualize, with hypertonic dehydration, water loss is greater than sodium. So you have your blood vessel, okay, and you have your cells. Okay. Water loss is greater than sodium. So if you lose a lot of water here, that's going to leave more sodium in the bloodstream than water because you're losing the water in the hypertonic dehydration, right? So when this happens, it causes a shift from intracellular to extracellular. It causes the water to shift from in the cell to the bloodstream. And that's because this is an area of higher sodium content. So think of when you think of a lot of salt and salt drawing water. So the water is going to shift there, out of the cell. And when that happens, it causes the cell to shrink. So you would give a hypotonic fluid, and the hypotonic or hypertonic dehydration is just the opposite of what it's talking about in the fluid. So hypotonic fluid is going to be hyposodium, okay? So it's going to be half normal saline. It's not going to have as much sodium, right? It's going to have more water because it's wanting to replace, it's wanting to shift the water back into the cells. And if you put more water in here, then it's going to shift the water back into the cell because you're going to put more water. The water concentration here is going to be higher than the sodium. Sodium content here is higher because you've already lost the water into the bloodstream, if that makes any sense whatsoever. So then it's going to put the fluid back into the cells. I may have confused you even more. If so, we can talk about that in class. Hypotonic dehydration, electrolyte loss is greater than the water loss. So water moves from the extracellular to the intracellular fluid, so just opposite of what we just shown. So the cells get bigger. And you will see this with hyponatremia. So if you don't have enough sodium. In hypotonic dehydration, you're going to give a hypertonic solution, such as D5 half normal saline. Overhydration is an excessive body fluid intake that can lead to heart failure. Cleft lip and palate. Cleft lip happens if it fails to fuse at 5 to 8 weeks in utero. Palate is fail of fusion at 9 to 12 weeks intrauterine. Cleft palate may occur separately. It can be unilateral or bilateral. Risk factors are hereditary, smoking, alcohol use, anticonvulsants such as Dilantin, and if they're deficient in folic acid. If a child has a cleft palate, you want to check them for other anomalies also, because it can be associated with many other problems. And think of whatever happened at the 9 to 12 week mark, okay? Think of how many organs and how many body systems are formed at that point. Cleft lip is an incomplete fusion of the oral cavity, and cleft palate is an incomplete fusion of the palatine plates. Here's pictures. This is a normal. This is a left unilateral cleft lip and palate, and this is a bilateral. Here is a picture of course, live newborns. The nurse wants to help promote bonding and support parents in providing care. A lot of times this is diagnosed on ultrasound, so the parents are aware of this before the child's born, but not always. This can affect self-esteem and body image. The referrals are going to be to plastic surgeons, orthodontists, and speech therapy. Surgery at 2 to 3 months of age. Pre-op, you want to assess the area and the infant's ability to suck, so you want to assess their nutrition level. Proper feeding, these infants can breastfeed. For a cleft lip, you want to encourage breastfeeding. If they're not breastfeeding, they want to use a wide-based nipple and squeeze the infant's cheeks together during feeds to decrease the gap. For a cleft palate, a special bottle is required. You may need to syringe feed. Supplementation after breastfeeding may be implemented because of issues creating enough suction, but they also can still breastfeed. Post-op, you want to watch for infection. Keep the infant pain-free so they don't cry and stress the suture line. Avoid pacifiers and nipples. Do eyes and O's and weights, and encourage bonding. Post-op elbow restraints may be needed also, and that's to help protect the site so the infant's not constantly messing with the incision site. Wound care and nutrition. Okay, so reflux. Gastric contents reflux back up into the esophagus, causing tissue damage, which is the GERD. Reflux usually resolves by 1 year of age. Signs and symptoms for infants: excessive spitting up, blood in the stool, failure to thrive. For children, heartburn, abdominal pain, and chest pain. It can be diagnosed with endoscopy or upper GI studies. The nursing care, think of your adults that have heartburn, okay? Small, frequent meals. You can thicken an infant's formula with rice cereal. Avoid caffeine and spicy foods. Position child with the head elevated at 30 degrees for 1 hour after meals. If it's actually GERD, so if there's actual damage of the esophagus, then maybe PYLORIC, which is a proton pump inhibitor. Surgery, we'll click on this here. Bear with me while I get the volume working here. Okay, well this is available through, if you click on your PowerPoint. For some reason the volume's not working today, so we're going to move on for time purposes. Pyloric stenosis. This is the thickening of the pyloric sphincter. You can see in the picture there. This is genetic. You will see projectile vomiting that occurs following a feeding. They're immediately hungry, failure to thrive, dehydration, and an olive-shaped mass in the right upper quadrant. Diagnosis is made by ultrasound. Surgery is done. Pre-op, you're going to give IV fluids because of dehydration. Do an NG tube, get a weight, do I&O. Post-op, you want to pay attention to pain control, assess for infection, and make sure the child's getting good nutrition. Let's see if the volume works on this one. moving on. Hirschsprung's disease. This is a congenital ganglionic megacolon causing decreased motility and obstruction. Lack of nerve cells in part or all of the enlarged intestine. The nerve cells signal muscles in the large intestine to push stool towards the anus. Increased risk if you have a family history. For a newborn, you will notice no meconium within the 24 to 48 hours after birth, abdominal distension, and they will refuse to eat. For an infant, you'll see failure to thrive, abdominal distension, vomiting, episodes of constipation, and watery diarrhea. For a child, failure to thrive, abdominal distension, constipation, and a foul-smelling ribbon-like stools. So if you ever see ribbon-like stools, you want to suspect Hirschsprung's disease. Diagnosis is done by rectal biopsy to confirm absence of the ganglion cells. Nursing care, nutrition before surgery, TPN or a low-fiber diet. Surgery focuses on removal of the aganglionic section of the bowel, possible colostomy. Pre-op, you want to pay attention to nutrition, bowel prep, and education. Post-op, you want to pay attention to pain control, assess the abdomen, surgical site, ostomy care, make referrals as necessary, and educate. Intussusception is, risk of this is if the child has cystic fibrosis. Assessment, they'll have sudden episodic abdominal pain and draw knees up and scream. Maybe an abdominal mass and current jelly stools. The sudden episodic abdominal pain will, the pain or the child will have their knees up to their chest. Diagnosis is made by ultrasound. This is an emergency. So emergency surgery is required, an NG tube, an air enema performed by a radiologist. So this is when the small intestine right here envelopes inside the large intestine. Okay, so if that's not fixed, obviously then part of that bowel will die.
So how long has she been having these episodes of intermittent crying out and then stand up, AccuCheck 125 and falling asleep? How long has that been going on?
About 2.5 hours.
2.5 hours. So what's happening? She'll basically
She wakes up screaming from sleep, like bloody murder, and then she'll scream for a few minutes and she'll put her head down and go back to sleep. It's like she was lethargic.
okay. All right. So she's almost like, but you can wake her up every time.
Yeah.
She's hard to wake up.
She's a little hard to wake up.
Okay. So intermittent crying episodes and then falling asleep.
Okay, so appendicitis. This is inflammation of the vermiform appendix, and this is related to obstruction by fecal matter. Know where my mind's at. Assessment, you will see abdominal pain in the right lower quadrant, but this is a late sign. Fever, decreased or absent vowel sounds. Diagnosis can be done by CBC, and a CT will show an enlarged appendix. Nursing care, you don't want to apply any heat to the abdomen. For a non-ruptured appendix, pre-op surgery, you're going to give IV fluids and an antibiotic. Post-op, you're going to do incision assessments, bowel sounds, pain control.
I'm sorry.
That's okay. And a respiratory assessment.
Look, you I see a light, but here you are, bless your heart.
For a
I gotta start asking. I'm going to do.
for a ruptured appendix, pre-op, you're going to do an NG tube, IV fluids, and an antibiotic. Post-op, you're going to do respiratory, vital signs, pain control, incision assessment, bowel sounds, IV fluids, antibiotics, and an NG. For a ruptured, you want to watch for peritonitis. Signs of that are fever, sudden increase in pain, a rigid abdomen, tachycardia, pallor, and chills. Celiac disease. This is in your textbook. It's sensitivity or abnormal immune response to protein, gluten factor found in grains. You're going to see steatorrhea, which is a bulky, foul-smelling, fatty stool, and this is related to malabsorption. Deficiency in fat-soluble vitamins such as A, D, K, and E. Malnourishment, distended abdomen. They're going to appear skinny with wasted buttocks, but face may be plump. Diagnosis is made by a history and physical, symptoms, a serum analysis, biopsy of the intestinal mucosa, and stool analysis. These kiddos are at increased risk for rickets, which is related to the loss of calcium from malabsorption of the vitamin D, and also iron deficiency anemia related to poor protein absorption. Dietary management is crucial and mainstay in the treatment of celiac disease. Parents need a great deal of nutritional counseling. Wheat, barley, rye, and oats should be avoided because of the gluten protein. They may need a water-soluble form of vitamin A and D and iron to correct their anemia. And here's a shopping list for gluten-free of what they can have and what they can't have. Constipation, it can become a vicious cycle of painful defecation, including the repression of the urge because of the pain. The child may become severely constipated and have episodes of diarrhea and encopresis, which is involuntary release of stool when the rectum can hold no more. So it's painful for them to go, so therefore they hold it because it's painful, and then it even gets more backed up. Hernia, an inguinal hernia, is a protrusion of the section of the bowel into the inguinal ring. Usually boys, and this is related to testes descending. There will be a lump in the left or right groin and may be apparent only when abdominal pressure increases. So if they cry, it's usually painless. Pain would indicate a bowel is incarcerated, which is emergent, so you don't have ischemia of the bowel. Treatment would be surgery. Keep suture line dry and free of urine and feces, and then assess for leg circulation.